Hello and welcome, everybody. On behalf of the Real Estate Board of Greater Vancouver, I'd like to thank you for joining us today for our COVID-19 Looking Back and Looking Ahead with Dr. Patricia Daly event. I'm one of the board's communication coordinators. My name is Jesse Lalime, and I've been with the board since 2007. Before we begin with our conversation with Dr. Daly today, I'd just like to mention that you can submit questions throughout the event using the Q&A section found in the bottom panel of your screen. Moving on to our event, we're honored today to have Chief Medical Officer and Vice President of Public Health for Vancouver Coastal Health, Dr. Patricia Daly, with us today. As Chief Medical Health Officer, her primary mandate is to improve the health of the more than 1 million people served by Vancouver Coastal Health. She's a key player in the fight against COVID-19 in BC, and we're excited to hear her insights today. Dr. Daly, welcome.
Hi, Jesse. Great to be here.
Thanks for joining us today. I understand you have a presentation you'd like to launch right into, so why don't you go ahead and get into that, and we'll get to the questions at the end.
Okay, that's great. I apologize in advance. I'm going to do a presentation, and I love to show data and graphs, so I'm going to show a few of those. I thought it might be great to start with a little bit of where we are currently with COVID-19. And a little bit about what we might expect in the months ahead. And as I was thinking back to give this presentation, of course, it's over a year now since we had our first case of COVID-19 in the province of BC. In fact, we were the second province in Canada to identify a case. That was back in January of 2020. We were also the first region in Canada to have an outbreak of COVID-19 in long-term care. And we had the first COVID-19 death in Canada in our health authority. It was actually in that long-term care facility, Lynn Valley Care Home. And so much has happened, of course, over the last year. And I'd like to just tell you where we are and what we might expect. So I'm going to start by just showing a graph from the World Health Organization. These are the reported COVID-19 cases and the number of deaths from around the world since the identification of this virus. And of course, you remember that the virus was first identified in Wuhan, China. The pandemic was declared early last year by the World Health Organization. It spread really to every region around the world. The graph you see is a graph we call an epidemic curve. And what it does is chart the number of cases essentially by week for the course of the pandemic. And they've also color-coded it by region of the world. So you can see that the Americas, North, South, and Central America, account for the largest number of COVID-19 cases, followed by Europe. And then Southeast Asia, Western Pacific, which is actually China, where the virus was first identified, has actually had a very small number of cases altogether. But what you do notice about this graph is that the peak of the epidemic curve was at the beginning of January of this year, and there's been a decline since that time. And that decline has been seen everywhere. And in fact, even when we look at the rise in cases, which was most steep after October, what we're seeing with COVID-19 around the world, and there's public health measures in place in all places around the world to try and contain the spread of the virus. I'll talk briefly about those. And of course, we're starting vaccination, but we haven't vaccinated a very large percentage of people. So this decline is occurring even though we don't have a large percentage of our population vaccinated to date. And one of the reasons is that COVID-19 is a respiratory virus. It's transmitted by droplets that people produce when they cough or they sneeze. These travel about 1 meter in the air and then fall to the ground. This transmission is very similar to other respiratory viruses like influenza. And similarly to other respiratory viruses, there does seem to be a seasonal pattern to COVID-19, especially and particularly now within the Northern Hemisphere, Europe and North America. The rise we saw in the fall and the decline we're seeing now is a pattern that we see each year with influenza. So a lot of the decline certainly is due to the public health measures we have in place, but this could be the normal seasonality of the virus. And you may recall that we had very few cases of COVID-19 in the spring. And in fact, this is the epidemic curve for Canada, dating right back to January of last year when we first saw cases. And you can see we had a first wave of cases. And just a caution here that in that first wave, we weren't testing everybody who had symptoms of COVID-19. So there probably were many more cases we didn't identify. We had a wave and then we had a real flattening of the curve, as we call it, in the summer. And this is very typical for respiratory viruses. And then in the fall, we saw an increase in cases. And just like we've seen elsewhere in the world, the peak in Canada was in early January. And we've seen quite a rapid decline ever since in just about every province. And even though you may read in the newspaper about concerns about new strains of the virus that are maybe more transmissible, and we have identified some of those in Canada, and they've identified them in many other places in the world, this decline is occurring even in places where those variants are circulating. Now, if you look at the number of cases here in Canada, you can see, or it may be a little hard to see, but it's 822,000 total cases in Canada. This was taken as of February 19th. We've had 21,000 deaths, which is a very large number. But if we just compare this to our neighbors to the south, the United States has had over almost 28 million cases of COVID-19, 500,000 deaths. They have a much higher rate of COVID-19 than we do. And in the Americas, Brazil is number 2 with over 10 million cases. So Canada has done relatively well, especially considering that we had our border with the United States. A lot of our initial transmission did occur from cases that came across the border from the United States. So again, because I love these curves, I'm showing you one now that compares British Columbia to other jurisdictions. And this is based on the rate of cases, not the absolute number, but the population rate, which is a better way to compare different countries that may have different populations. BC is in red, and we've had a relatively flat epidemic curve compared to some other places. Ontario is in dark blue. They had a bigger rise and a worsening situation early this year than we did. Alberta, you may recall, our neighbor just to the east, had quite a big rise in December. And then you see the UK, where there was a dramatic increase in January, and the United States as well. But what you'll notice is in all these places, including the US, where they've vaccinated about 13% of the population, the UK has done more. There's been a very steep decline in cases now going into February. And we see that in South Africa, where they have a variant strain they're concerned about. Almost every country in the world, we're seeing the same decline and actually in Canada, all provinces now are about the same level, less than the Maritimes, but you'll see that provinces are starting to lift some of the public health orders that were put in place to try and stop the spread. And this is because we're starting to see this decline in cases. This is the same graph, but now we show deaths. And BC has done better than other places. We've had a lower rate of death. Some of that is has to do with the work we've done to stop spread in long-term care facilities, where most of our deaths have occurred. We also have had very good hospital care in BC for COVID-19 cases, and this data has been published in Canada. The care received in our intensive care units, particularly here in the Lower Mainland, this is where the publication came from, had a lower death rate than many other jurisdictions around the world. So that's some good news for us. Now, this is the same curve, but now this is for Vancouver Coastal Health. So Vancouver Coastal Health, which is the region for which I'm the Chief Medical Health Officer, is a region that has about 1.2 million people. It includes the city of Vancouver, Richmond, all the North Shore communities. It also includes the Sea to Sky communities, Whistler, Pemberton, the Sunshine Coast, up to Powell River, Gibson, Sechelt. It also includes one of the most remote areas of the province, the Central Coast, including Bella Bella, Bella Coola, and it includes 14 First Nations communities. And I should acknowledge that I'm today talking to you from the lands of the Coast Salish, the Musqueam, Squamish, and the Tsleil-Waututh Nation. But we actually serve First Nation communities right up until the Central Coast. Now, our epidemic curve looks a lot like the Canadian curve. We had a little peak in the spring, very flat in the summer. Then, as you may remember, in order to stop the spread of COVID-19 initially, we put in place a number of public health orders that were pretty severe, closing many businesses, closing schools, guidelines for people to socially distance. And then we saw a real flattening of the curve in the summer. And as public health experts, we were aware that the measures that we put in place had harmful effects. They certainly helped to stop the spread. For example, we asked physicians and healthcare providers not to provide in-person care if at all possible, to provide virtual care. We saw a real decline in visits to our emergency departments and people getting healthcare services that were actually probably essential to their health and well-being. We also know that the social isolation created by those measures had harmful effects. even our other public health emergency, which is ongoing in the province, and that's our increase in opioid overdose deaths, got dramatically worse in the spring when we put these measures in place. So we actually made a deliberate decision to lift those public health orders in August. We knew we'd see an increase in cases, and we got ready for that. So a lot of the work done, for example, by WorkSafe BC to work with various industries so that they had COVID safety plans in place and they were ready to reopen in a safe way was very helpful. We did start to reopen businesses in the summer, and there was an increase in cases, but we were able to protect those who were most vulnerable, and I'll show you that data in a moment. And then we opened schools, and there was a lot of concern among parents about reopening schools. But you can see that after we opened schools, there was not an increase in cases. Cases were pretty flat. And actually, the data we have now shows that schools are quite safe places, that there's very little COVID transmission in schools. Children are less likely to be infected with COVID-19 and to transmit it to others, especially young children. So we feel quite comfortable that schools can remain open. But despite all those efforts, there was a real rise in November in cases. And this was seen across Canada, North America, in Europe. And this, we do believe, is in part because with the onset of the colder weather, we do start to see more circulation in general of respiratory viruses. We then put in place additional orders, as you know, beginning in the Lower Mainland. This is Dr. Bonnie Henry, followed by the rest of the province. And we have seen a flattening of the curve again. Now we're seeing about, it's at a higher rate. We're getting about 100 cases per day now in the Vancouver coastal region. But overall, we have seen that those orders were effective in, again, flattening the curve. Now, I should say that of the cases we've had in Vancouver Coastal Health since the start of the pandemic, and we've had about 18,000 cases in our health authority. There's been 78,000 total in BC. The health region to the east of us, Fraser Health, has had the highest rate of COVID-19. Of our 18,000 cases, only about 5% required hospital care. So 95% of cases were quite mild disease. And in fact, in young adults in particular, COVID-19 is quite a mild disease. Some people have very minimal symptoms. There's even some cases with almost no symptoms. And the virus resolves on its own without any particular treatment. Of those who are hospitalized, a small percentage will require quite intense treatment in our intensive care units, but that's less than 2% of all cases. And overall, we've had 2% of the cases have died in our health authority. And that's been a total since the start of the pandemic of 385 deaths in our region. Now, 2/3 of those deaths have been residents of long-term care facilities experiencing outbreaks. And this is the population where we've seen the most severe outcomes from COVID-19. This is not just in Vancouver Coastal, but across Canada. And in fact, the very first outbreak in a long-term care facility in Canada was in our health authority, and the first death from COVID-19 in Canada, as I mentioned, in Vancouver Coastal Health. We've learned a great deal about how to both work to prevent introduction of COVID-19 into long-term care and prevent transmission. But nonetheless, this is a setting where the virus can spread. Similarly, other respiratory viruses we know can spread in long-term care, like influenza. And so 2/3 of our deaths, as I said, have been in long-term care. Now, of our 385 deaths, 73% of them have been people over 80 years of age. And the median age of death, so that's the middle of all the people who died, the median age in the middle is 87 years of age. And what we know is that the risk of serious illness and death in COVID-19 is very, very closely tied to the age of the person infected. In fact, there's been no deaths in our health authority in anyone under the age of 40. And that's, if we look at influenza, you may not know this, but every year in Canada, very young children can get quite severe illness from influenza, and there are usually deaths among young children. We have not seen that with COVID-19, so it's less severe a disease in young children than some other things like the flu, and the deaths have primarily been in those over 80 years of age. Now, how is the virus transmitted? I talked about the fact that it's through droplet spread. One thing we've learned since the start of the pandemic, we're pretty confident now about how it's spread. It behaves exactly like other respiratory viruses that are spread this way. It's not airborne like measles or chickenpox. It's not, at the very beginning, you may remember there was a lot of concern about cleaning of surfaces and that you could be infected by touching surfaces. In fact, that's less, we've come to understand that's less likely to be a way the virus is transmitted, especially outdoor settings. You may not remember this, but initially the city closed all the playgrounds and they were actually quite worried about reopening them. Do they need any special cleaning? The virus does not survive well outdoors, and there really is no risk from playgrounds and other surfaces in outdoor settings. And we now know that it really is that direct person-to-person contact with someone who's infected that results in transmission. Now, one of the challenges is that people may get very mild symptoms and not realize they have COVID-19, and you're also infectious for up to 2 days before your symptoms start. So there can be spread before people even know they're sick. What we've learned is that, and as I said, we've now followed up 18,000 cases, and we have a team of public health staff here in my health authority that follow up every single case. We have an amazing laboratory system in BC. If you go for a COVID test, we will get the result within 24 hours, and we will contact you within 24 hours, and we will identify your close contacts as well. You will be isolated for 10 days after the onset of your symptoms, and we will isolate your close contacts for 14 days after their exposure. And that's because we know that they could come down with COVID-19 any time between 1 and 14 days after their exposure. What we do know is that most cases we're seeing are linked to a confirmed case or cluster. So when we get cases reported to us every day, I mentioned about 100, 120 cases, most of them actually are known to be contacts of other cases. That transmission is most common in household settings. And that's been consistent since the start of the pandemic. I mentioned we've seen very little transmission in schools. It's not zero, but the COVID safety plans in schools are working really well. And actually, there's been very little transmission in businesses with good COVID safety plans. And I have to give credit to WorkSafe BC. They've done a really an excellent job providing good safety advice across all business sectors. When we do see clusters in workplaces, it's usually staff members who have socialized with one another, and the transmission has occurred outside the workplace setting. If those businesses have a good COVID safety plan, the risk is really low of transmission. I just want to show you, this is kind of a funny looking graph. This is for British Columbia. This is the age distribution of all the cases that we've seen of COVID-19 from last spring up until the current. And you can see at the bottom the age ranges. So one thing you'll notice is on the bottom here are children in light blue and dark blue. Children up to age 10 make up 10% of our population. They've only been about 3% of our cases. So they're less likely to be infected than older adults. And we're doing a lot of testing in kids. They just are less likely to acquire COVID-19. The other age group that's been quite protected are the elderly over 80. So initially there were a lot of cases in people over 80. We certainly had outbreaks in nursing homes. What we're seeing at the top here among those 70 to 79 and 80 plus is that they're taking good care to protect themselves from COVID-19. They're not at an age where they're out working. They're limiting their interactions. And actually now the bulk of the cases we're seeing are among young working age adults. So you can see the 20 to 29 age group is where we see most of the cases, followed by the 30 to 39. And this is often through social interactions. The reason this is important is that as we start vaccinating our population, we're going to start with the oldest age groups. We're actually going to continue to see transmission occurring amongst younger adults for some period of time because they're not going to be eligible for vaccination until further along in our campaign. So I think that's important to point out. But it does show that actually our COVID safety plans have worked in protecting the very old and the very young. And as a result, even as we've had more cases recently, I mentioned the peak in January, we didn't have as many hospitalizations as we saw in the spring because older people are protecting themselves and they're the ones most likely to have severe disease. So some good news now, just to end on the vaccination campaign. Really, the development of COVID-19 vaccines, and we have 2 licensed vaccines now licensed vaccines in Canada and more to come very shortly. This is an unbelievable triumph of science and medicine. We did not know about this virus infected human beings and was first recognized in early 2020. And to have a vaccine, an effective and safe vaccine developed less than a year later, that's never occurred in the history of medicine. So this is an incredible triumph. And actually the technology used to develop these vaccines could revolutionize other development of other vaccines in the future. Now, as you'll hear, the first vaccines arrived in Canada the week of December 15th. We got a small amount here in Vancouver Coastal Health, and in those early weeks in December, our Minister of Health had prioritized protecting those most vulnerable to severe disease as our first priority. And so we started by vaccinating the staff, and then very quickly the residents in long-term care. And I can tell you that, so that was the work of our public health teams. In the last couple of weeks in December, early January, we got our long-term care residents vaccinated and the staff. This has been incredibly successful after a single dose in stopping the spread of COVID-19 in long-term care. In the fall, when we had a lot of COVID-19 circulating, we had up to 15 outbreaks in long-term care facilities. We had many deaths. You may have read about some of the more severe outbreaks in the news. We have 0 long-term care outbreaks right now in Vancouver Coastal Health. And in fact, this is an article that was in the National Post. They actually referenced Vancouver Coastal Health and the fact that we've seen this dramatic reduction in outbreaks in long-term care. The vaccine has been incredibly successful. And that's good news as we roll it out to other populations, because some vaccines don't work very well in frail elderly people. This vaccine did work very well in that population. So I mentioned we have 2 licensed vaccines. They're made with a new technology it actually makes it easier and quicker to produce vaccines. It's called messenger RNA. And it's a bit of RNA code that's contained within a lipid molecule injected like any vaccine into your arm. It enters your cell and it instructs your cell to produce those spike proteins that are on the surface of the COVID-19 virus. It doesn't have any virus in it. When those spike proteins are produced, your body produces what we call antibodies against them. And this is the protective army that you need in the event that you are subsequently exposed to COVID-19. Highly effective. So 2 doses of the vaccine, 95% effective in preventing symptomatic COVID-19. That's really amazing results. And in fact, a single dose is over 90% effective. The second dose is really a booster. Very, very safe vaccines. And I mentioned the vaccination campaign began the week of December 15th in Canada. Now, BC has a 4-phase COVID-19 immunization plan. This is available on the Ministry of Health website. We started, I mentioned, with those at greatest risk of severe illness and death, those who live in long-term care, followed by those in assisted living, really the frail elderly population. And then we expanded to healthcare workers who are considered essential for caring for those with COVID-19. And this is very similar to what was done across Canada and North America. We are still really in phase 1 and 2. As you may know, we've had a slowdown in our delivery of our vaccines in Canada in recent weeks. That's been of cause for concern. Our vaccines come from plants that are outside of Canada. And the Pfizer vaccine in particular, which is the vaccine we received the greatest volume of vaccine from that company. The manufacturing plant in Europe was for a period of time producing much lower volumes because they were renovating in order to increase their production capacity. We've now just this week had more vaccine arriving and we'll be able to move forward with larger numbers vaccinated. And you've heard the Minister of Health talk about the next phases of vaccination in April. April to June, we expect to get 2.6 million doses of both Pfizer and Moderna, and there may be other vaccines licensed, and then even more in July to September. So I won't go into the details, but I mentioned we've been vaccinating primarily those living in long-term care and assisted living, a number of healthcare workers, but you've also heard that beginning in March, we will start to vaccinate the general population, and we're starting with a strategy to vaccinate those who are oldest first, because they're at greatest risk of severe disease, and we'll be starting with those who are over 80 years of age. And you can anticipate that the Minister of Health will be announcing further details about that very, very soon. And then we'll be continuing after that with vaccination of other population groups as we work our way down from 80 plus down to younger age groups. And I'm going to stop there. And Jesse, I'll now turn it back to you because I know there'll probably be lots of questions and I'm happy to answer them all.
That's great. We appreciate that. That was a very informative presentation. You touched on the vaccine rollout there. We heard a little bit about delays last month. Is there any effect on the timelines from those delays?
Yes. So the phases that were put out by the Ministry of Health were based on our original allotment of vaccine and our anticipated delivery schedule. And then we did have a slowdown, especially in the weeks in February, end of January, February. And so we have delayed things a little bit. The good news is the companies are committed to the full volume of doses expected by the end of March. So we'll be able to catch up. And even this week, we're starting to get more vaccines. So it was a slowdown for a period of time. I know that caused some anxiety because even delaying vaccination for a few weeks and those who are anticipating getting it people can be anxious. But the good news is this week, and actually we're now really focused on our healthcare workers, getting them vaccinated before we move out to the general population. We're really increasing vaccinations this week. So we will get going in a bigger way over the weeks to come.
Good news for everybody. You touched on WorkSafe and the job they did and continue to do, making sure workplaces are safe. They've had safety protocols in place for the real estate industry for some time now. What do you think are the most important things realtors need to focus on when it comes to practicing real estate safely?
And I'm aware of those protocols because I will tell you from my personal experience, one of my children in the summer was I went with him because he was considering buying a condo, and I went to a number of open houses, and I didn't tell people who I was. So I was observing the protocols that the realtors had in place, all quite good. I would say there was, if you look at those safety protocols, initially there was quite a bit of emphasis on, environmental cleaning and not touching surfaces, which we know now is probably less of a risk. I think the most important things are not coming to work if you're ill, and if you're interacting with your clients and your customers, making sure that you don't have that in-person interaction if they are feeling sick, or if they've been told that they're a contact of COVID-19 case, because as I mentioned, most transmission occurs from people who are known contacts of cases. So, and the concern is, of course, for young adults and realtors are in that working age group. You may get very mild disease. So you may be someone who normally goes to work when you have a cold, and you want to serve your clients. If you're feeling unwell, especially if you've got a fever and a new onset of a cough, you should go for testing. You shouldn't go to work. You shouldn't interact with clients if they're feeling unwell. And if you're interacting, let's say in an open house, I know that we're now wearing masks when we're in indoor settings, but it's really staying 2 meters apart is more important than wearing masks. So keeping that physical distancing. One of the things that worried me about the masks is that when people started wearing them regularly, they stopped physically distancing, and actually the physical distancing is more important than the non-medical masks. So those are the two things. Don't come to work if you're sick or interact with sick clients, and keeping that physical distancing is really the best thing you can do.
Great advice for our members. Let's turn it into a little personal side now. You've been on this for a year now, as all of us have been dealing with this for almost a year now. Just tell us a little bit about how your life kind of changed in those early days. It must have been very strange.
It was strange. The work that we're doing now for COVID-19 is very similar to work that some of the public health work that we do normally. So people may not realize that there's a whole long list of what we call communicable diseases that are reported to public health, and we do the same kind of follow-up we do for COVID-19. If you have measles, if you have hepatitis, if you have salmonella, we hear about those, we investigate cases and contacts. So that's the normal work that we do, but that's only a small part of what my public health team does. I had about 12 staff that normally did that kind of work. We've increased it to 270 people, and all they're doing is following up COVID. So almost all the work that we're doing, and we have public health staff who normally inspect restaurants and do a whole bunch of other really interesting work. Almost all of them now have been focused on COVID-19. So it's become a full-time job managing the spread of COVID-19 to the detriment of some other important public health work. So we've tried to keep up some basic services, the regular immunizing of children and some of the other regular work, but it's been a complete change. And it has been, 7 days a week, 24/7 job. We don't stop on the weekends. Our teams are working all through the weekends. I mentioned we follow up every case within 24 hours. That's not just Monday to Friday, that's 7 days a week.
When you first took this job, did you ever expect or think that anything like this could happen? What was your first reaction when this news started to break?
Well, you may not know this, but in public health, we've long been worried about pandemics. And we actually had developed pandemic plans in the event that we did have a declared pandemic. We actually had a previous influenza pandemic, you may remember, in 2009. And so we had these plans that were based on the experience in the 1918 flu pandemic. In the 1950s and 60s, there were pandemics. So we were always on the ready for this. And I have to say that the previous flu pandemic was nothing compared to COVID-19. I don't think we anticipated a brand new virus like this, but I had also been through the experience of the SARS outbreak, the previous SARS outbreak in 2002. We only had a small number of cases in BC. It's also a coronavirus, less easily transmitted than COVID-19. So it never spread as broadly. So I had those experiences, and this is something we always planned for, but of course, it's living through it is much different than the planning. And the fact that it's gone on this long, it's been a real challenge for a very small public health team.
Mm-hmm. Yeah, that was going to be one of my questions, was what's one thing about the work that you do that people may not realize that you're doing? And it sounds like planning for these kind of things is always something that's a priority for you. Is that right?
Yeah, that kind of planning is something we did, and I don't think people realize that. So we were not unprepared. We actually, for example, were talking about setting up the mass clinics for vaccinating the general public. We had a whole chapter with detailing exactly what we needed for a mass clinic. So we're not starting from scratch, which is good news. We have a lot of experience, and we've done big mass immunization campaigns before too. People may not know that. One of my first things that I dealt with in my public health career was we were anticipating a large measles outbreak in BC, and we actually vaccinated all children from age 1 to about 22 within a 1-year period with a dose of measles vaccine to prevent an outbreak. So it hadn't arrived. And we were successful in doing that. So we've done these kind of things before. People may not realize that. So it's not like we were unprepared, but of course, the magnitude of this and the impact on all of society is quite dramatic.
Mm. And so there's some light at the end of the tunnel here with the vaccine plans in place. What's the biggest concern you have about where we're at right now? What do you think maybe could go sideways from here if we're not careful?
I have a lot of confidence in the vaccine, and I know everyone's anxious about when their turn will come up. It's been a long time for people waiting for this. They can't wait to be vaccinated, and it's hard to tell them to be patient, that your time will come. I have a lot of confidence that this will roll out, and from what we've seen so far, this vaccine is working extremely well. So that's good news. What worries me a little bit is that throughout the pandemic, some of the things that we've done have caused harm in themselves. So I mentioned some of the lockdowns. The opioid overdose crisis, which is, we had the worst year for overdose deaths last year we've ever had, and people don't talk about that as much. We actually had many more people die of an overdose in our region than died of COVID, and they died at a younger age group. There's also other harms from the lockdowns, the mental health harms to young people. A generation of young people lost a year out of their lives when they would graduate high school, go to university, make social connections. There's the economic hardship on whole industries of people, those living in poverty. The fact that people maybe didn't come for good healthcare services, including some prevention services like screening for breast cancer or other cancers. We may see a long-term negative impact from some of those things. Even what we did in nursing homes and long-term care to try and protect frail elderly people, we didn't allow visitors. They lost connections with their families. That had negative impacts. So I do worry about the negative impacts of the things that we've done to control the spread of COVID. We have to have a balance, and the public needs to understand that. We're not going to get to 0 cases, even with rolling out the vaccine. We're not vaccinating children. This virus is never going to go away. We've only ever eliminated one pathogen in the history of mankind, and that was smallpox. So I think we have to understand that it's about controlling the spread and severe disease, but we have to get back to all the things that keep us healthy as well.
Yeah, you mentioned mental wellness. What are some of the things you do to keep yourself grounded in what must be the most stressful period of your professional career?
Yes. Well, one thing I consider, I'm lucky in one way in that I never stop coming to work. And I know for other people, my husband, for example, he's one of the people that's been primarily working from home, and Zoom is a great thing, but human connection is something we all need. And I've been able to come to work every day and work with an amazing team of public health colleagues. So that's helped me. But personally, I try and do some exercise every day. I try and get my 30 minutes of, at least moderate physical activity every day. And I've been pretty good. I have an old treadmill at home I go on, or I go out for a walk. And I told people right from the beginning, get outside. I actually think we did better in BC in the spring because the weather was better and people could be outdoors more, and transmission of COVID occurs more indoors. So I get out, I do that 30 minutes of physical activity. I do my best to try and sleep well and, have a reasonably healthy diet, but those are really the main, and then interacting with colleagues, because like everybody else, there's been no traveling. I've missed seeing family members. So those have been challenges.
Mm. Yeah, well, British Columbia is one of the most beautiful places to be,
Yes.
one of the most beautiful places to live. Given that, you're probably likely going to be ready for a vacation when this is all over. Where are you thinking about taking that first vacation when it's finally time?
Yes, I'm sure we all are, and I dream about vacations, but it's not that exciting. I mentioned I haven't been able to see family, so I have my father lives in Ontario, and my mother-in-law. I haven't seen them since 2019. Actually, I have a child who lives in the United States. I haven't been able to see him since December of 2019. So those are the first places I'll go to visit my family, and then I'll plan those other nice vacations. But I've said to my husband, we're not planning anything until we're not going to try and guess when the quarantine guidelines come off, and that's not in my control. We're going to, we'll wait, and when things are lifted, then we'll plan for travel. And those would be the first places I go to see my family.
Yes, I think there are a lot of people in that same boat. That's all I have. I'd like to open it up to some of the questions from our members now, and we've got a few here. One of our members just wondering about the vaccine not being suitable for people with high blood pressure. Can you speak to that and whether that's true or not?
That is not true. These are very safe vaccines. The only people who can't receive the vaccine are people who have either have a very severe allergic reaction to the first dose of the vaccine, or the vaccines contain a compound that's used that's in a few other pharmaceutical agents. If you have a severe allergy to that particular compound, then you can't be vaccinated. But people with chronic health conditions, even people whose immune systems might be weakened, pregnant women, that they didn't do any of the trials of the vaccine on pregnant women, but if we've told pregnant women who are healthcare workers, your risk of COVID-19, even if there's no real theoretical risk with the vaccine, we're vaccinating pregnant women who are breastfeeding. So there's very few people who cannot receive the vaccine.
Another question we have coming in is just about with the highest number of cases being people between ages 20 and 40, why would this age group not be vaccinated before others?
Well, I think that, that's a debate that you see it amongst the experts and in the public. I do support the approach we're taking here in BC that and this is an ethical decision really, to protect those at greatest risk of severe disease. Seeing firsthand the outbreaks in long-term care, the impact on families and staff who work there, we got the vaccine out to that population as soon as possible. So I do support this strategy that is proceeding. If there are other vaccines licensed in Canada, we have more vaccine, we may look at it as a combination strategy that also targets some younger adults. That's the debate. Some people have suggested, why don't we do the age groups for which the virus is most likely to be transmitted? But I do think ethically, almost everyone has landed on, let's start with those at greatest risk of severe disease first. And I do support that, especially now with limited supply. When we open it up, I think, that's a different story when we get more vaccine.
Mm-hmm. And this follow-up, or that's not really a follow-up, but this question kind of follows up on that. How will people be notified when and where they can start receiving their vaccinations?
Well, stay tuned very soon. You've heard Minister Dixon Bonnie Henry talk about this, and I think you can expect very soon that the minister will provide the details of how the vaccine will be rolled out to those who are over 80 years of age. And it will start next month, in the month of March. So just stay tuned for that.
That sounds good. Another question about people with pre-existing conditions. What would be the best vaccine for people with asthma? Do people have a choice which one of the vaccines they can get?
There is no choice right now. And what I say to people who ask me this is, if you're offered a COVID vaccine, take it. And actually the two vaccines we have now, they're made with very similar technology. The safety profile is nearly identical. They're both safe for people with asthma.
Another question we have from one of our members. Do you recommend getting tested if you're symptomatic or just self-quarantining for 10 days?
I think that if you have a new onset of fever and cough, you should go for testing for COVID-19. Having said that, early on in the pandemic, we weren't testing everybody. We said those with mild symptoms, you don't have to be tested, just stay home for 10 days. And that will work well too. Because if you test positive for COVID-19, what we do is we have you isolate for 10 days after your onset of symptoms, and then you're not infectious anymore. And so, there are some people who, for example, we've had cases in families, and, an adult may get sick, this is typical, and then one of their children develops symptoms, and they don't want to take them out and get them tested. So we just tell them to isolate their child for 10 days, and that's acceptable too. But generally, the testing is not for your own benefit. I think it does help people who have to isolate for 10 days. They're more likely to do it if they know they're COVID-19 positive. It does help us track the spread of the virus in the population. So if you have those new onset fever and cough, or if you've been in contact with someone and you develop the symptoms, we would recommend you go for testing. There's lots of test sites available. You won't have to wait. We have lots of staff working there.
One question's coming in about the variants. What do we know about the vaccine's effectiveness against these new variants?
So there's been a lot in the media about the variants, and I just want to, first of all, reassure you, the variants are not different viruses. This is all COVID-19, and this is a virus that over time, there are changes. It doesn't change as quickly, for example, as the flu vaccine, but we've seen, several dozen variants altogether in the province since we've been tracking this. And some variants seem more likely to be transmitted in populations than others. And I think that's the concern with some of the recently identified variants. The UK has probably done the best surveillance for variants, and they've talked about the UK variant. And just to give you an example, when we look at people who are close contacts of COVID-19 cases, we did this analysis, about 9% of them will develop COVID. So that tells you how transmissible it is. Everyone we identify who's a close contact, and that's anybody who's been within face-to-face contact with a case for 15 minutes or more, no protection, about 9% of them will come down with COVID. They found the same in the UK. That was their baseline rate. With the UK variant, it was about 30% higher. So maybe 12 or 13% of people contacts would come down. So for an individual, it's not a huge difference. They don't cause more severe disease, but at a population level, it might mean that there's more cases. So what we're doing is really just the same thing we do with any case of COVID. It just is more important than ever that if you have COVID-19, you do have to stay isolated for the 10-day period. If you're a contact, we ask you to isolate for 2 weeks after your exposure, and you have to comply with that. The good news around the variants, at least with the UK variants and some of the others, is the vaccines do seem to be effective against those variants. Some of the countries that have the highest percentage of people vaccinated, like Israel and the UK, do have a predominance of that variant, and it's working. The vaccine is working. And I think you will also see, we're going to have new vaccines licensed. They may have slightly different effectiveness. But the good news about these vaccines is they can also be adjusted by the manufacturer to provide better protection over variants if needed. If we find that right now we don't have a lot of the variants circulating here, if we find that some vaccines are less effective, I think they would be adjusted over time. So I wouldn't worry too much about it. The evidence we have now is the vaccine is very effective against the virus that's circulating here.
One other question about the vaccine that's come in is about how long of a protection period does it offer?
We don't know that because it is a new vaccine, of course. And I mentioned that a single dose is very effective. And I see someone asked, have you thought about only giving everyone one dose first? And actually, we've increased the length of time between doses because we know one dose is so effective. And that could change in future again if we wanted to give more first doses. The second dose is really a booster for longer term protection, but we won't know that with we'll have to monitor this over time. We've also been monitoring people who have COVID infection to see how long because you do get protection when you're infected against a reinfection. And just the literature has just been published to show at least 6 months of protection after an infection. But again, I wouldn't worry too much about this because if we find over time the vaccine protection goes down, then they'll just recommend a booster. So just like you get a tetanus booster every 10 years, you get a flu shot every year, if the vaccine doesn't provide long-term protection, then I imagine in future they would just recommend regular booster doses.
For people who have had COVID or think they may have, is there a way for them to get tested to see if they have antibodies?
No, we are not doing regular testing for antibodies in the general population. We do it for research purposes. I would say if you had the diagnosis is made with the nasal swab or the gargle, and that will tell you if you've had it. If you're not certain and the vaccine comes around, you can get vaccinated. Just go and get vaccinated. If you haven't had it, and even people who've had COVID-19, we're vaccinating them. We just wait until 3 months after their infection. And the only reason we do that is because we know they're protected for at least that long. We want to save the vaccine for people who don't have protection. So there's no harm in getting vaccinated if you've had COVID, and you don't need to check for the antibodies.
Now, you mentioned before that transmission is primarily from droplets and direct person-to-person contact. One of our questions here is asking why public spaces insist on hand sanitizer and wipes Does the virus live on surfaces at all? And I know you said it doesn't do well on surfaces, but I assume that's just out of an abundance of caution.
Yes, I think initially we were more concerned about what we call contact spread. You probably read some studies that show the virus could live, especially on hard, like stainless steel surfaces. Is probably a greater concern in healthcare facilities, let's say where you have an outbreak and you've got a lot of virus around, but it's still good practice. You know, as a public health person, we've been saying to people for years, washing your hands regularly can prevent a lot of infections. So I do think this is good practice. What we have done, though, is we don't want, for example, in schools, teachers are spending a lot of time cleaning surfaces, probably not needed as much, or daycares. We've said, okay, clean your surfaces a couple of times a day, but you don't have to clean it after everyone touches something. So we've de-emphasized it a bit, but I will tell you, it's just good general public health advice. Before COVID came, when I got home from work every day, the first thing I do when I walk in the house is wash my hands, because I've been out and about touching things. And try not to touch your face when you're out and about. This is one of the issues with masks too. I worry people touch your face more because viruses can enter your eyes, your nose, or your mouth. And it's often because we inadvertently touch our face. So hand washing is just good public health practice.
And you're just talking about the masks there and earlier as well. One of the questions coming in is, would you recommend a double mask?
No, I would not. And this is where I disagree with Dr. Fauci, who's amazing, but I know he's talked about wearing a double mask. Our experts, our infection control physicians, don't actually recommend against double masks. And this is because the masks have to be breathable. If you put more and more coverings over your face, it's harder to breathe and you're more likely to touch your face and contaminate yourself. So we don't actually know how good the non-medical masks are that people wear, that you buy in your stores. We do testing for the medical masks that are used in healthcare facilities, and we know they're very effective. And there we tell our staff, don't put on 2 of them. 1 is fine. But even for people out and about, just be careful because you have to be able to breathe through the mask. So generally 1 mask is sufficient.
Another question's come in about traveling within the province. What your thoughts on that are at this time?
Well, the travel restrictions are really for people outside of Canada, the quarantine requirements when people come back. There is no order preventing travel within Canada or even within the province. This has just been a recommendation from Dr. Bonnie Henry that we have seen that if people travel around that there can be transmission of COVID-19 between jurisdictions. So we've recommended against non-essential travel. And that's what I would say. I mean, there are people who do need to travel. They need to travel for their work, even across we have truckers bringing all our food across the border. They're essential. They're traveling every day. There are people who need to travel for work. There are people who have to see family. We have people coming from other countries because their family member has cancer and they need to come here. So of course you might need to travel, but we've recommended that you try not to take your vacation by traveling somewhere. There's lots of good things we can do locally here. As we've talked about, we live in one of the nicest parts of the world.
We have a couple more questions about the vaccine coming in. Will younger people with other underlying health conditions be prioritized in any way?
I think we're going to get more clarification of this from the Ministry of Health. So the rollout is primarily age-based, but there has been discussion about people with some severe underlying health conditions being moved up. We haven't got more details on that yet, but by and large, most people will be vaccinated in their age group as it's been invited for vaccination. But there may be a small number, yes, with quite severe conditions who might be prioritized and done sooner.
Once you've been vaccinated, are you still able to transmit the virus?
That is a question that we don't know for certain. So the trials that were done on the vaccine didn't examine that. The way the trials were done, they had about 60,000 people, half were given the vaccine, half were given a placebo, so they didn't know what they had. And then people were advised, if you get symptoms of COVID-19, go and get tested. So, and then we know that the vaccine was 95% effective in preventing symptomatic COVID-19. What they didn't do is swab everybody after vaccination to see, well, maybe you could get the virus, but not get symptoms and still transmit it to others. Now those studies are now underway. Places like Israel, where they've vaccinated a high percentage of the population, are starting to do that research. But until we know for certain that the vaccine can also prevent transmission, the advice we're giving to people who are vaccinated, you still need to quarantine if you travel. If you're a healthcare worker, you still need to wear all your masks and your gloves and your all the things that are recommended. If you're a contact of a case, we're still going to make you isolate for 14 days because we can't be certain. So until we have further evidence to be certain that the vaccines can prevent transmission, then we're going to treat, there will be no change for those who are vaccinated compared to those who aren't. It's not a free pass to start traveling or going without your masks, for example.
When we get to vaccinations, one of the questions coming in is about vaccination sites, where they would be set up, and will there be jobs available at these sites?
That planning is well underway now. So you may know that we are planning our what we call our mass vaccination strategy. I mentioned that we all actually had plans for this in our pandemic plans, and there'll be more details coming very soon about the locations where you can get vaccinated. So there will be some large sites. They're going to be around the province. We want to be sure we can reach people in every community. The strategy will be different in small communities versus big communities. And there's active recruitment underway actually for people to work in some of those sites. So you can go on the Health Authority websites if you're interested, and you might see some jobs available.
One question's coming in is getting back to the mask, specifically the mask versus the face shield, the plastic covering that covers your nose and mouth. What is your opinion, the face mask versus the face shield? Are they both as effective as each other, or? Yeah,
so they're not a replacement for one another. So the recommendation for the public is to wear a face covering or mask rather than a face shield. Face shields, unfortunately, they're open at the bottom, so droplets could still come out. If you go into a healthcare facility, you will see that the staff will wear a medical grade mask and a shield that's to protect their eyes. But the face shield does not replace the mask. So if you're out doing your work, you should be wearing that. I know it's hard because people like to see one another's face, and it's hard when you're speaking, but the face shield is not a replacement for a mask.
Well, I think the timing's worked out great here. We've got one more question for you, and it's about Dr. Tam's recent mentioning of the threat of a third wave. What does that mean for our region?
I don't think anyone can predict exactly what's going to happen with COVID-19. I know you read about modeling. Modeling is when some of our mathematicians try and use the data that what we've seen so far to predict what might happen in future, but there's lots of unknowns and guesswork involved in those models. What I would say is that if we can roll the vaccine out efficiently, we do hope that will prevent a future wave. We're seeing right now across Canada a reduction in cases. Some of that may be, as I said at the beginning, because generally as we get into the spring months, we see that respiratory viruses start to wane a bit. If we can get people vaccinated quickly, I do think, I have confidence that can prevent another big wave of cases. So that's what I would tell you. When your time comes to be vaccinated, please go and get vaccinated.
Get in line.
Yeah.
All right. Well, thank you so much for your time today. We really appreciate it. We're out of questions and we're just about a time at the end of our session. So thank you so much for joining us. We really appreciate the insights. And yeah, continued thanks for all the great work you're doing and your team. We really all appreciate it.
Thank you. It's my pleasure, Jesse.
Thanks, Dr. Daly. Now, we'd also love to hear some feedback from our members on today's session. When you log off, you'll get a pop-up link to our event survey. We'd love it if you could send us your thoughts by completing our survey. And I'd also like to just quickly mention some of our upcoming events. We've got one coming up on Friday, February 26th, where we're sitting down with Black Knight to discuss what's coming for Paragon in 2021. On Friday, March 5th, we're holding a Rise and Shine movement and nutrition wellness event. On Tuesday, March 23rd, we'll be diving into stratas with our What Will 2021 Bring for Strata Corporations event. And on Thursday, March 25th, we're going to be sitting down with representatives from the City of Burnaby for a community plan update for the City of Burnaby. And on March 26th, we'll have a home inspections event featuring Tom Monroe. Thank you so much for attending. We really appreciate it. Enjoy the rest of your day.